Welcome to Pulse and Pressors, where critical care gets crystal clear. Today, we're breaking down cardiac output and cardiac index. These are core hemodynamic values we monitor at the bedside, not just numbers, but guides to life-saving therapy. We'll explore how they're measured, what high and low values mean, and how they shape our treatment decisions in the ICU. There are two main ways to measure cardiac output. The Fick method calculates oxygen consumption divided by the difference between arterial and venous oxygen content. It's elegant, but rarely used at the bedside because it requires precise VO2 measurement. In the ICU, we rely on thermodilution. A known volume of cold saline is injected into the right atrium, and the pulmonary artery catheter measures how quickly the blood warms back up. A low cardiac index, especially below 2.2, is the definition of cardiogenic shock. Causes include left ventricular pump failure, right ventricular infarction, tamponade, or severe hypovolemia. The patient will often show hypotension, low mixed venous saturation, rising lactate, and cold extremities. Management depends on the physiology. If preload is low, fluids. If contractility is failing, inotropes like dobutamine or milrinone. If ischemia is the culprit, revascularization. Afterload reduction may help a weak left ventricular eject forward. Each intervention hinges on why the cardiac output is low. A high cardiac index may seem reassuring, but it's often pathological. In sepsis, anemia, thyrotoxicosis, cirrhosis, or AV fistula, the heart pumps large volumes, but tissues still starve because extraction is impaired. The hallmark is high flow, but low oxygen utilization. Management is not to blunt cardiac output, but to treat the underlying driver: antibiotics for sepsis, thyroid control, transfusion for anemia. Remember, high cardiac index does not always equal adequate perfusion. The real value of cardiac output and cardiac index is how they guide treatment in context with wedge pressure, systemic vascular resistance, and oxygenation. Low output with high wedge is classic LV failure. Treat with inotropes and diuretics. Low output with low wedge means preload is the problem. Fluids are the fix. If wedge is normal, but output is low, think RV infarction, pulmonary embolism, or distributive shock. And if output is high, focus on the underlying cause. These patterns turn numbers into actionable hemodynamics. To close, cardiac output and cardiac index are essential for understanding the pump's performance. Cardiac output is total blood flow. Cardiac index adjusts for body size. Normal cardiac output is 4 to 8 liters, index 2.5 to 4. In the ICU, we measure this by thermodilution with the PA catheter. But remember, it's never just the number. Low or high values must be interpreted with wedge, SVR, SVO2, lab values, imaging, and the clinical picture. That's how we turn monitoring into precision therapy. This is Pulse and Pressors, providing a daily education on the marvels of the human body. Share if you found this interesting, and let us know in the comments if you frequently use Fick method.